Okay, moving on to epithelial tumors. The first disorder is seborrheic keratosis. This is a benign proliferation of squamous cells. It commonly arises in the elderly. On gross exam, you see a raised, discolored plaque, usually on the extremities or the face, and this is what it looks like. And it has a classic, quote-unquote, stuck-on appearance, so that when you look at this lesion, it looks like a coin that you can just peel away from the surface of the skin. Were you to examine this on histology, you would see a raised lesion. This line represents sort of the surface of the skin, and this represents the bump on the skin. And one of the hallmarks is that it contains these circular spaces with abundant pink keratin. And these circular spaces with abundant pink keratin are called pseudocysts. So again, you have a proliferation of the squamous cells with these pseudocysts producing this coin-like stuck-on lesion on the surface of the skin. Now, seborrheic keratoses are normal in individuals as they age. However, it is possible to have the sudden onset of multiple seborrheic keratoses, like dozens and dozens of seborrheic keratoses. This is called a lesser Trelot sign, particularly high yield, and it suggests an underlying carcinoma, usually of the GI tract, and so it's probably a paraneoplastic syndrome. But you do need to know, for the purposes of boards, that if you get multiple seborrheic keratoses all of a sudden, think about a carcinoma, especially in the GI tract. Here's a picture just showing you multiple seborrheic keratoses that have arisen all of a sudden, again hinting that there may be an underlying carcinoma of the GI tract. Acanthosis nigricans, remember the word acanthosis means a thick epidermis, and nigricans implies that it becomes dark. So you get epidermal hyperplasia with darkening of the skin. The epidermal hyperplasia makes the skin feel velvet-like. And so again, it becomes a little thicker than normal. This usually occurs in the groin or axilla and is associated with insulin resistance. So for example, type 2 diabetics can get it, or malignancy. For example, patients with gastric carcinoma can develop acanthosis nigricans, and that's particularly high yield. Here's a clinical picture of acanthosis nigricans. You can't really appreciate the thickening of the skin, but I think you can appreciate that it is darker than normal. Basal cell carcinoma is a malignant proliferation of basal cells of the epidermis, and the risk factors are all based on exposure to UVB sunlight. Now remember that within sunlight, UVB is the most carcinogenic component, and UVB can induce DNA damage. And so when there's UVB-induced DNA damage, that would increase the risk for basal cell carcinoma. So the risk factors are all going to be based on UVB. For example, prolonged exposure to sunlight, excess UVB. Albinism, where you don't have pigment to the skin, so you're not protected against UVB. And finally, a disorder called xeroderma pigmentosum, which is particularly high yield. Now in xeroderma pigmentosum, you have an autosomal recessive defect in enzymes that are necessary for nucleotide excision repair. Now let's go back and remind ourselves that when sunlight hits DNA in a cell, it causes formation of pyrimidine dimers. These pyrimidine dimers are normally excised by something called the nucleotide excision repair pathway. The enzymes of the nucleotide excision repair pathway remove the pyrimidine dimers and repair that defect. Now imagine if a patient has a defect in the ability to repair these pyrimidine dimers, then there's going to be an increased risk in basal cell carcinoma. And so that's exactly what happens in xeroderma pigmentosum. The patients do not have their nucleotide excision repair pathway, and therefore they get pyrimidine dimers, increasing their risk for basal cell carcinoma. Basal cell carcinoma has a very classic appearance clinically. You get this elevated nodule here with a central area of ulceration here, and it's surrounded by all of these dilated blood vessels, which are called telangiectasias. And so this is the classic appearance of basal cell carcinoma. It's also important to note for the purposes of board exams that one of the classic locations that basal cell carcinoma can arise in is the upper lip. They like you to know that basal cell carcinoma arises on the upper lip. Here's a picture of basal cell carcinoma on histology. You get these nodules here. This whole thing represents tumor. There's also tumor here and here. You get these nodules of basal cells, which are characterized by peripheral palisading. Now, when you say the word palisading, what you mean is that the cells are lining up against some space. So can you notice here that this particular layer of cells looks a little bit darker than the rest of the cells? And that's because this layer is lining up against the edge, and that's called peripheral palisading. And that's a classic finding on histology of basal cell carcinoma. The treatment for basal cell carcinoma is surgical excision, and it very rarely metastasizes. It has an excellent prognosis. Squamous cell carcinoma is a malignant proliferation of squamous cells. The risk factors are all based on exposure to UVB sunlight, which can then induce DNA damage by forming pyrimidine dimers. So of course, exposure to sunlight would be a risk factor, albinism would be a risk factor, and xeroderma pigmentosum when you don't have the enzymes necessary to repair those pyrimidine dimers. Additional risk factors for squamous cell carcinoma are very high yield for the board exam, so I threw them in here. The first is immunosuppressive therapy. If you have a patient that receives a transplant and you put them on immunosuppressive therapy, the most common cancer that would then develop in that patient would be squamous cell carcinoma. That's high yield. Arsenic poisoning also increases the risk for squamous cell carcinoma of the skin. We've already talked about that. And chronic inflammation can also increase the risk for squamous cell carcinoma of the skin. For example, if there's a scar from a burn or there's a draining sinus tract, these can also increase the risk of squamous cell carcinoma of the skin. Squamous cell carcinoma presents as an ulcerated nodular mass, usually on the face and classically involving the lower lip. Now remember that the upper lip is involved by basal cell carcinoma classically, and the lower lip is involved by squamous cell carcinoma classically. And I don't know, one of the students told me that he hates memorizing things and that this is a bunch of BS. So BS on top and bottom. But anyway, basal cell on the upper lip and squamous cell carcinoma on the lower lip. The treatment is excision, and metastasis would be uncommon. It has an excellent prognosis. Actinic keratosis is a precursor to squamous cell carcinoma. It presents as a hyperkeratotic scaly plaque, so you have extra keratin. That's why it's called actinic keratosis, usually on the face, back, or neck. And it's a precursor to squamous cell carcinoma, and it usually doesn't, but it can progress to the development of squamous cell carcinoma. So really, I would say that this is a dysplasia of the squamous cells. Keratoacanthoma is a very well-differentiated squamous cell carcinoma. Now, what you need to know for the purposes of board exams is that this tumor develops very rapidly, basically within a period of weeks, and then regresses just as quickly, so also within weeks. And it presents as a cup-shaped tumor with keratin debris in the center. So if this is the surface of the skin, you would see this tumor that looks like this with all this keratin debris in the center. And again, that's a keratoacanthoma. And that concludes our discussion of epithelial tumors.